trauma. Splenic trauma poses a potentially life-threatening situation. This risk is true especially because the spleen is the organ most commonly injured when thoracoabdominal trauma occurs, and splenic injuries represent 25% of all blunt injuries to the abdominal viscera. Subcapsular hematoma less than 10% of surface area. Capsular tear of less than 1 cm in depth. This is grade 1. Grade 2 subcapsular hematoma 10 to 50% of surface area, or intraparenchymal hematoma less than 5 cm in diameter, or laceration 1 to 3 cm in depth not involving the trabecular vessels. Grade 3 subcapsular hematoma greater than 50% of surface area, or expanding and ruptured subcapsular or parenchymal hematoma. Intraparenchymal hematoma of greater than 5 cm expanding, or laceration greater than 3 cm in depth or involving trabecular vessels. Grade 4 laceration involving segmental or hilar vessels with devascularizations of more than 25% of the spleen result in infarcted spleen. Grade 4 splenic injuries. Grade 5 splenic injuries, shattered spleen or hilar vascular injury. Splenic trauma, as in this case, contrast enhanced CT shows perisplenic fluid without identification of laceration in a patient who sustained blunt abdominal trauma. Large amount of pelvic fluid seen. This promoting laparotomy, during which a small laceration found not evident in scan, but point of alarm is this fluid around spleen. Splenic trauma, contrast enhanced CT show massive fluid collection in the upper abdomen with a chronic subcapsular splenic hematoma grade 3 injury. Splenic trauma and contrast enhanced CT show complex lower pole splenic laceration grade 2 splenic injury. Splenic trauma contrast enhanced CT shows complex laceration extending to the hilum, grade 4 injury. CT shows contained splenic hematoma. This treated by observation gradually resolve over several weeks. This is splenic hematoma, as we seen in image before, it is now resolved without surgery. Splenic rupture with hemoperitoneum, as we see this splenic rupture with this is large area of hemoperitoneum, and we see in this CT scan with intravenous oral contrast presence of splenic laceration. This is splenic laceration hypoattenuating area irregular within intraparenchymal associated with hemorrhage and subcapsular region of spleen. This hematoma. Not absence of hemoperitoneum, no blood in the intraperitoneum. Intraparenchymal splenic laceration, subcapsular hematoma. Active bleeding into subcapsular hematoma with hemoperitoneum. As we see here, subcapsular fluid collection around spleen, the areas of high attenuation adjacent to this area demonstrations of extravasated intravenous contrast material. This represents contrast material radiologically equal to active bleeding. This area of high attenuations represent extravasant IV contrast impress active bleeding. As we see also fluid in right paracolic gutter compatible with hemoperitoneum. Splenic injury, as we see in ultrasound, small perisplenic fluid, spleen abnormal because of persistence of symptoms. We do CT scan for this patient 8 days later. We found splenic fracture with a well-marginated hematoma. Delayed splenic rupture, bleeding due to splenic injury occurring more than 48 hours after blunt trauma, following an apparently normal CT examination due to rupture of subcapsular splenic hematomas. Contrast blush. Contrast blush is defined as an area of high density with density measurement within 10 ounce field compared to the nearby vessel like aorta. Differential diagnosis is active arterial extravasation, post-traumatic pseudoaneurysm, post-traumatic AV fistula. When contrast blush present, this is differential diagnosis of contrast blush.